our last chronic disease seminar unit of the semester, and we're thrilled to save the best for last. We have with us Dr. Biana Roykh, who actually just joined Columbia in March of 2020. So talk about auspicious dates to join an institution. She has her DDS from University of California, San Francisco, UCSF. She also has her MPH from Berkeley, the Berkeley School of Public Health. She currently is the Senior Associate Dean for Clinical Affairs at the College of Dental Medicine, and has, over just the course of 2 years and during a pandemic, made tremendous strides in community health within Washington Heights and other areas of New York, which you'll hear about in just a minute. So we're thrilled to welcome her at the School of Public Health today. Again, I've learned so much from our interaction. She's participated in our interprofessional workshops that we've done and led, and her and her team are just doing tremendous things, and we're here to hear a little bit more. And then also to think with your own work in community health, how you might be able to collaborate with Dr. Roykh's team. So thank you so much for coming today. And Laura will read the questions as the people. So please just put your questions in the chat box. And without any further ado, thank you so much, Dr. Roykh.
Good afternoon, everybody. Thank you so much, Mary Beth, for this kind invitation to present and for the introduction. And it's nice to see everybody here and on Zoom. As Mary Beth said, please do ask questions as we go along. Sometimes it's nice to have a conversation rather than hold your thoughts till the end. I don't mind to be interrupted, and Laura's gonna ping me if somebody has a question online. So just want to share with you today, this is an overview of the presentation. I'd like to give you a little bit of history about the Dent Care program here at Columbia, a word about the opportunities that we see with mobile medical units and the direction that we've pursued in the last couple of years, a word about our curriculum and increased focus on service learning. I want to share with you a little bit about some pilots that are going on right now and are focusing on integrated care approaches with regards to oral health and total health. Share a little bit about our partnerships and how we think about workforce development and what opportunities might lie ahead. And also share some challenges, some thoughts about possible scaling and some next steps. So Columbia has a very rich history of oral health services in the community. The mobile medical unit that we had here at Columbia existed for about 20 years. And in addition to mobile services, Columbia has a history of service in school-based health centers. We have been at it for over 20 years. The program was started under former DM Allen from Macola, and it had a lot of community support and a lot of public support for the programming for many years. The focus of our what we call empowerment zone is Northern Manhattan, Washington Heights area. And this sort of reconfirmation of that attention to this area took place through the Community Benefits Agreement when the university was building the Manhattanville campus. They came together with the community, and there were a series of about 300 commitments that the university made to the community as part of that build out and of that campus. The dental school, the College of Dental Medicine, has 2 of these 300 commitments. One of them is focused on Elder Smile, and that's preventive and care services for the elderly in the target area. And the second one is to operate and provide services on a mobile dental center at least until the year 2035. There's no funding that's associated with it that's coming from campus, but the dental school is committing itself to this service to the community as part of this work. So you can see that while we do travel sometimes beyond these 17 zip codes, we do focus most of our partnerships and our efforts in 13 zip codes of Upper Manhattan and 4 zip codes in the South of Bronx. So as I mentioned, the target population is, generally underserved ethnic minority urban community. It is about 70% Hispanic Americans, and there are about 13 to 15% of patients who are over the age of 65. Care is often uncoordinated for this community. There are high rates of chronic illnesses, comorbidities, and a lot of these social determinants of health factors that we often see in underserved communities. So, primary care is often the first point of contact for patients in this community. And so we think about, where does oral health fit in within that framework? So just a word about service learning. The long, rich history that I shared with you really hasn't focused significant attention on students in the past. The doctors were hired to serve in school-based centers. They were hired to work on the mobile dental center. And that has been really the model for the last 20 years. We had initially, when the first programs were released, a lot of state and local support for running of these programs. But over the last, that was probably in place for the first decade, and then sort of the second decade of the program, those supports slowly began to wane away because, whenever state budget had any cuts to be done, oral health, unfortunately, was often the first ones to be on the chopping block. So what we learned over the last 5 years is that some of these commitments were difficult to sustain. It was not a sustainability plan if we were to be leaning in on sort of the old model of relying on doctors to be hired into a lot of these settings. So the pandemic threw another curveball at us. It was difficult. The dental school was shut down for about 5 months. Students were not here. Our model of care is really reliant on students to provide services, both in the dental school and in some of our other settings. So we had to really shift gears and think about, well, what is the future? How is this going to look? A lot of our volunteer faculty retired given the pandemic and were not coming back into these care settings. A lot of the facilities that we were maintaining in the schools were aging out, and it was difficult to confirm airflow and kind of all, have all of the same bells and whistles that for safety that we were able to put into place in our 4 walls here to be able to translate to the community was very difficult. So we had to start thinking about, what is this new future? What is Dent Care 2.0? How are things going to look? Who are going to be our partners? And how are we going to reconfirm our commitments in the community? So you can see here a photograph of, this is October of 2021. I'm proud to say that dentistry was one of the first on the lines back with community partners to provide screenings and to be back in services. This is a screening event that took place at the Grant House and the Manhattanville houses, where our students and faculty and hygienists went in to provide screening services for residents of these housing communities. These individuals haven't had access for about a year and a half or so by then, and so this was very well received. We are restarting our operations with outreach to daycare centers and are bringing on board new Head Start programs and reestablishing connections with the existing Head Start programs as well. So it's sort of these 2 arms, the elderly through the Elder Smile program and early intervention for school-based and Head Start centers. Yes.
Can you tell us a little bit, at what point of their training?
Absolutely. So dental students spend the first year of their curriculum in biomedical sciences with the medical students from VPNS. In the second year, they start to do preclinical simulation activities where they learn the tools of the trade, if you will. And in the third year is when students transition into clinical care. So most of their curriculum in the 3rd and 4th years becomes patient focused. They still have some lectures, they still have some hands-on kind of activities, but they really focus on comprehensive services. And then they also rotate through a set of different rotations like specialty rotations, oral surgery, and also community-based rotations. So these are third-year students who are about halfway in through their third year. So that means that they've already had all of that biomedical training, all of the preclinical simulation, and have already been under the vigilant guidance of our faculty here in our four walls of the College of General Medicine for about 6 months. And then all of these activities that they are doing in the community are supervised in the same manner as it is supervised here in the dental school. So they travel with a dental faculty who's credentialed faculty of CDM, and usually a hygienist. And I can tell you a little bit about what we're doing with the hygienist in this setting.
I'm sorry, Dr. Roykh, there was a question request that you repeat questions for people in the room because we can't hear them on the Zoom.
Sorry. I'm sorry, Lynn, is it a question?
Oh, so if there's a question from the audience in the room, if you could repeat it when you're answering it.
Audience was, what year are the students in their training when they go out into the community? That was the question from Mary Beth. And what I just shared is that these students are in their clinical training years, third and fourth year dental students. In the photograph, you see students who are about halfway through their third year.
Perfect. Thank you very much.
And opportunities that exist within that. The dental hygienist, the American Dental Association has been trying to uplift a new workforce for the profession called Community Dental Healthcare Coordinator. It's kind of like a healthcare worker, parallel for the dental world. And it could be a registered dental assistant, but ideally it would be a dental hygienist who can provide a series of preventive services for the patient. But it would also understand the unique challenges of working with a specific community and the cultural considerations, the language considerations of that community, and would be able to liaise and coordinate a set of services in a manner that would be the most culturally appropriate for that patient, that would be the most accepting to that patient. So we have our inaugural community dental healthcare coordinator. His name is Daniel Lopez, who is our dental hygienist and is sort of the lead in the community based learning and program. And he helps to coordinate a set of things. So when the students and the faculty are out in the field providing services, you'll see, we'll talk a little about it later, that there are limitations with what we can provide in remote areas, right? On the mobile van or in these types of makeshift care settings. And so a lot of times follow-up is needed. And this is where we lean in on the help of almost like a navigator coordinator to help bridge and bring people into a care setting when they need more services. So this is a great opportunity for Mailman and the School of Public Health with respect to coordination of services and thinking about programming that can tie people to a dental home. Okay. So we have also spent the last year building a partnership with Arch Care, which is a pretty large organization in the New York area. They have a number of different outfits that they operate, including long-term care facilities. They have a special needs hospital. They also have 4 PACE centers. PACE is program for all-inclusive care for the elderly. And so they operate 4 PACE centers in the New York area, in the Bronx, in Harlem. There's one in Dobbs Ferry and one on Staten Island. So we have been partnering with them to bring services to their members. Their members receive primary care in those PACE centers, but they don't have access to oral health. And so we've been able to bridge that for them by bringing our mobile center to them, provide services for their seniors. We've also restarted operations with the medical students from VPNS with sort of a student run, but faculty supported program inside St. Mary's Episcopal Church on 125th in Harlem. This is a place where, a lot of underdocumented patients might come, or refugees, sometimes, people who don't have shelter or have been in and out of temporary housing and really can't get to even a dental clinic, like a student dental clinic. So we've been able to restart those services again, middle of 2021, and are now elevating that service by bringing a mobile van once a month. So we'll do a screening on one of the Tuesdays, line people up, and then actually bring patients into a mobile van where we can deliver a little bit more services. And I'll share you the photos in a little bit. We have a new partnership with the Ambulatory Care Network, specifically focused on pediatrics. And I'll show you some pictures for that in just a moment. And the ones that you see here in orange are new collaborations that are currently emerging and that we're hoping to launch for fiscal year 23. And that's deepening our commitments to patients with special needs, specifically developmental disabilities. And we're building a partnership with Arch Care that has this 72-bed hospital. We have an emerging partnership with New York City Autism School. That would be sort of our version of school-based, but we would be able to bring mobile services to the school. And with respect to research and scholarly work, we're hoping to be of service to all of us, which is, some of you might know, this is a national sort of precision medicine endeavor, and they're looking to partner with us in the community because it's hard for them to reach a lot of those type of communities. And they would love to follow a service that provides clinical services, and then they can embed with the additional abilities to collect samples. A word about the mobile center. As I mentioned before, the old mobile dental clinic was in operation for 20 years. It's lived its good life. It was pretty beaten when I got here. I saw it. It looked pretty sad. It needed to be retired and in the process of being retired. We've been fortunate to receive funding from the Delta Dental Association of California to support a new mobile dental clinic. And it was a little bit interrupted because of COVID, but ultimately we were able to launch it in the fall of 2021. So in November, we had the unveiling and ribbon cutting. It is modeled after the Precision Dental Center clinic that was built in Vanderbilt 5. And the VC5 clinic came online in about 2018. And it's 48 dental chairs that are what we call smart chairs that can actually collect a lot of information about the patient, like their blood pressure. They have cameras that can monitor provider interaction with the patient. So it's got structured and unstructured data that it actually collects. The tethered instruments that are on the dental unit, how they run, how long they run, all of that data is sort of big data that's aggregated to understand a little bit more about the service that's being provided to the patient. The AI on it is now actually able to determine whether care is being done by a third-year dental student versus a fourth-year dental student. It can actually distinguish and can serve as it's pretty, it's pretty cool. It's just, it knows just by the speed of how quickly the handpiece is moving, how long the procedure is taking. It's able to pretty accurately determine what level provider is taking care of the patient. And it's meant to serve as sort of an early warning system, right? So as faculty members, we generally supervise with an 8-to-1 ratio for 8 students with patients, with a faculty member attending and kind of moving from patient to patient. Of course, we also have dental assistants, and we have sometimes specialist faculty and hygienists in that setting as well, but it's generally 1 attending dentist to 8. And so we have a monitoring station where the doctor can actually see, and the AI will, it helps the dentist to see if something is an outlier, if something is not trending based on the procedure that's logged in and the level of provider. If something is trending in a way that maybe the faculty member should go over and check in sooner rather than later. So they actually have a camera, they're observing the interactions, and are able to kind of lean in on that additional information. The mobile clinic was built with the same vision in mind. This has the tremendous potential of what we call, reducing bias in AI data gathering, right? If you think about it, what information are we collecting? We're collecting information from patients who are able to access healthcare, right? If we're not collecting information on patients who are not able to access healthcare, right? So this was very important to our Dean Stoller, that this mobile clinic is, has the same capability, same data gathering capability as we have in the main clinic care, so that we can, as much as possible, it's only 2 dental chairs, but as much as possible, be able to bring the same technology into the communities we serve outside our 4 walls. So it has 2 dental chairs. It is fully Epic enabled. Epic is our new integrated shared record. Our dental students are trained to navigate that record just like nursing students do, just like VPNS students do, just like all the licensed providers do. It has a sterilization area, so we can process smaller number of instruments, but we could do a set of processing there. And we added vaccine refrigeration onto the van, and I can tell you a little bit about why we did that. We started last year, really towards the tail end of 2021, was what we call Vaccination Wednesdays. And it led by doctors Mayer and Myers. It's really funny. So Dr. Dodi Meyer is from the ACN, and she's a community pediatrician, and Dr. Aaron Myers is actually our chief dental officer. He's a pediatric dentist. And so the 2 of them have really helped to shape the program. And it took us a while to get it up and running. The initial contact that Dodi and I made was in May of 2020, when the pandemic was really affecting all of us, but it was also affecting our children, because the kids were not able to get in to see their pediatricians, to get their milestone checkups, to get their preventive vaccinations. And we were promised that the Department of Health would, speed along all the approvals, and that we would be able to get community pediatricians onto the mobile van, so we could show up as pop-up clinics and do, preventive vaccine services with community pediatricians and residents on site, and dental residents on site to provide any kind of oral health kind of screenings or prevention. It took longer than we expected. I can tell you it didn't get turned around in a month, but finally in 2021, we were able to ultimately launch the program. And it had to pivot a few times as the pandemic kept doing its curveballs for us. With the Omicron really surging in December and January, we really had to pause that and pivot and turn more into PCR testing. And so again, these are partnerships that have evolved given the nature of what's been going on in our communities. But we've been able to mobilize the mobile dental center into different care settings, given the familiarity and the partnerships that were being built. The second pilot that I want to share with you today is the pilot with the School of Nursing that focused on telehealth and, again, early screening and prevention for homebound elderly. So we know that all the factors that influence livelihood and care access for patients in this community in Northern Manhattan are only exacerbated for those who are homebound. What we learned is that the Independence at Home demonstration project that was done about 10 years ago was focused on what kind of improvements do we get if we put primary care and on the front lines and bring primary care to the homes of people. We saw that it really had cost savings with that program, and it reduced re-hospitalizations for patients who received primary care services in their care settings when they couldn't access it. So with that sort of principle in mind, we collaborated with the School of Nursing to say, well, why don't we bring oral health services to these patients? They're equally having a hard time accessing a dentist. Many more times harder to access a dentist for a homebound elderly person than it is for a regular person, pandemic or not. And wouldn't it be nice to be at the forefront of some of these things and prevent emergency visits or more serious infections if we can screen earlier and intervene earlier? So telehealth was really surging, and it was emerging as a new technology and a new innovative way to provide services during that time. We learned that some people said, well, what can dentists do on telehealth, really? Like, what could you actually do on telehealth? And impressively, the private industry has been leveraging telehealth even before the pandemic. So the orthodontists, this is, your braces and many of you have heard about Invisalign, right? This is clear aligners therapy, have been more and more leaning in on the telehealth technology to convenience the patient, right? That they would be able to do a set of monitoring with patients by giving them multiple trays worth at any given time. And then they would do a mobile check-in just to see how things are tracking, if the patients have any questions, and then give them the approval to take the next set of trays. So it has been already happening in dentistry. And of course, during the pandemic, we had to really think about how else can we use the technology. The College of Dental Medicine, under superb guidance of our Chief Medical Officer, Dr. Perlman, developed actually an algorithm during the height of the pandemic to figure out, okay, how do we predictably guide patients as to whether they need to come in and be seen, or could we manage somebody medically, or what do we need to recommend for this patient, right? Because we were really trying to prevent people from going to the emergency rooms that were already crowded with COVID patients. We wanted to also minimize them traveling to CDM, given the nature of what the pandemic was doing in April, May, June of 2020. So the algorithm was built in Epic, and it took in a lot of input from state and local agencies, CDC guidance, ADA guidance, NYP guidance, and it sort of kind of carved together. And so we would have providers on telehealth asking a series of questions that would then provide a clinical decision support as to whether the patient needs to be seen right away, or we could manage them medically in some other ways, or what recommendations to give. So it kind of helped to standardize what we recommended to patients, rather than just more of a, my opinion, right, and what I think. So we've been leveraging telehealth during those months. And when the opportunity with the School of Nursing came about, we also said, okay, we need to be able to have eyes into the patient's mouth. And we have a nurse that is already going to see these patients bedside. Eyes on this patient, the way the nurse can get eyes on this patient when we don't have dental providers next to her. So the pilot that we worked on is we trained a nurse practitioner who was going into the homes on the use of a basic intraoral camera, that it's a plug and play that she would plug into her laptop. She would come in with her own Wi-Fi kind of hotspot into the patient's home. And there would be a dentist with residents and dental students on the other line. And the nurse would just basically use the intraoral wand to show the dentist and the dental students what she's seeing. Okay. And so we bridged this gap. She basically was able to bring our healthcare, dental care providers into the patient's home. And we would connect with the patient, we'd connect with their care providers, home aid, sometimes family members would join the call as well, and talk through a set of urgencies and preventive measures that we could take, oral hygiene instructions. And if something was more urgent, we provided a set of coordinated activities to help transport the patient for care. So this was very interesting. It's still going on now, and we're scaling up to now be able to actually, these patients oftentimes are homebound, but they're not necessarily bedbound. So if we're able to bring the mobile center to them or closer to them, we actually are able to lean in on a set of services to bring the patient onto the van, to provide some, minimally invasive kind of services with some x-rays and cleanings and some urgent interventions to help arrest cavities, and sometimes patients have sore spots, their dentures change over time, the tissues change over time, so we're able to do lining or adjustments just to bring a person that immediate comfort that they so well deserve. Yes. Nursing has already a program that when patients are dismissed from hospital or they're going from one care facility to another, they're assigned into the service to have a nurse go in to monitor their care. And so this is somebody that comes in on a daily basis and does activities of daily living and assessment. Sometimes it's wound care and a set of different things that the nurse follows. So we're just tapping into the same network that the School of Nursing has already been serving. Their target area is, again, Inwood and Washington Heights. And so it aligns very well with our core mission for the population that we're serving. And what we're saying is that oral health is health, period. And so if we can add oral health assessment into the overall assessment that the nurse is able to do for the patient, it's a major win, right? We're now reviewing systems, including the mouth. Okay. And so that's been a big pivotal change. It's reshaping the curriculum. The nurse practitioner students are now learning a lot more about oral health and dental care settings. In fact, we have expanded the collaboration that we now have nurse practitioners rotating through the College of Dental Medicine through the intake rotation. And during that intake of a patient, the dental students do their set of assessments, and the nurse practitioners are now helping to do PHQ-2, and then do a depression screening. They're able to do heart and lung sounds. We're collecting information about social determinants of health and are able to talk through a number of items that way as well. So it's a lot more enriching for the dental students, as you can imagine, to have the nurse practitioner there and kind of learn how they're doing review of systems. It's very informative for the nurse practitioners to learn a lot about oral health and kind of the challenges and systemic connection that it has with the rest of the body. So this is a small pilot that has led to innovation in the curriculum, both in the School of Medicine and the School of Dentistry. And we continue to innovate. Our next project for this new academic year is to create, I don't know if we can make it a full curricular component. It might end up being an elective that dental students would go with nursing students, with Nurse Marie. I have a picture of her. This is Nurse Marie on the upper right. That they could go with Nurse Marie to the patient's homes. So, but perhaps not only do we have a telehealth faculty with students on telehealth, but we'd actually have a dental student right there with the nursing student and with Nurse Marie. And they might even be able to do a set of very minimal kind of prevention, such as applying fluoride, showing how to, a little bit more involved kind of oral hygiene instructions, a little bit more work with the home, the home nurse or the home aide. Very interestingly, I sat through one of the community board meetings, Community Board 12. What I learned from the community is that the home health aides don't touch the mouth. I don't know where the misinformation came about that somehow they could be accused of elder abuse if they help to do something in the mouth or help to put the dentures in and out of the mouth. So a lot of the times the daily maintenance that the patients get help with, showering, using the restroom, cleaning up, turning them, over and brushing their hair and in kind of sponge baths, nothing's done for oral health. They're not helping them to brush their teeth. So if patients have mobility issues, the home aides are usually are not doing that. So there's a little bit of advocacy going on right now with that to help dispel the myth that it's not elder abuse, to help them get the dentures out of the mouth and clean the dentures and brush teeth. So it's just something that it seems to me we're trying to get to the source of all of this, but it seems to me that maybe there was an incident, somebody misunderstood something, and out of this one bad experience came out, policies from home health agencies that just sort of, give guidance to not do that, this is not part of what we offer, that somehow this is different from the rest of everything else. And so we're working with social worker. I forgot to mention that participants in this pilot, it's very interdisciplinary. So we have social work interns from from the College of Dental Medicine that has a social work, rotation program, internship program. We have physical therapy students that come and join because they sometimes have considerations. Well, if we were to move a patient and get them onto the van, we have a wheelchair lift, what would be the necessary things to, to get patients situated. So it's very well attended by multiple programs. And we're learning a lot. It really is a way to experiment and learn and see how the different disciplines can come together. We touched on those is, it's hard to do interventional care bedside, although we're starting to think about, what might we bring with us that's mobile where we can achieve that. During COVID, it was very limiting because, again, we don't have any control over aerosolization in somebody's home. We don't know how fast things turn over, and it was difficult to consider, but we can consider it now. A lot of these patients have Medicaid, but some have only Medicare. Medicare does not cover for oral health, although now with Medicare Advantage, it's highly unregulated, but there are programs that are coming out that are offering oral health coverage. Again, it's the wild, wild west. The payers are just all over the place. Some of it is just only emergency care and some of it is full care, but it's not really quite clear what you're signing up for at this point in time when you get these services. So we've been adjusting and providing services at no charge whenever necessary. When patients are Medicare only beneficiaries and is not a Medicaid payer, we would just, regardless, we would just provide those services. So, these are some of the logistics. Not all patients can be moved onto a mobile van, and again, leaning in on social work to help us coordinate a set of activities for patients. We've certainly done that, but these programs need more structure. And again, this is just a pilot stage at this point in time. Some next steps, there's grant opportunities. We have received some grant funding from Delta Dental for this program. There's a lot of interest in this program. There's interest at the national level as well, with regards to getting nurse practitioners as a workforce that can actually influence a lot of sort of preventive oral health activities in the care settings and in their work. VetSmile, which is an organization that has been charged to help the VAs find a care network for the veterans. 85% of veterans do not have dental benefits. Only 15% of veterans have dental benefits. They would have had to be injured in the war or something really significant for them to qualify for dental benefits. And the VA has nowhere to send these people for oral health services. And up until about a year ago, the VA couldn't even rightfully recommend for them to go a particular place for dental services because it was not a VA program. So through this VetSmile, it's a waiver that has been approved. It's a 5-year waiver opportunity. And they're working to create networks of colleges, dental clinics, FQHCs, and various to be able to build a national network for veterans to go to. It's still not a covered service for them, but hopefully there are reduced fees, different from private practice, where they can receive some of these dental services. So some of the patients that Nurse Marie sees are also veterans without care access. We hope to be able to bundle and advocate for some bundling of services. So if a patient has a particular condition, kidney transplant or some immunosuppression, or maybe cancer therapy, needs to be on chemo, needs to have radiation, having disease in the mouth can really wreak havoc for these patients. So there is some opportunities that we're discussing right now with VetSmile leadership on another waiver to see if we can advocate for bundling. So if you have these ICD-10 conditions, that oral health would be sort of included as part of that medical benefit. So these are just some next steps. You guys know that Senate Majority Leader Senate Schumer proposed a coverage plan for Medicare beneficiaries, but it didn't pass this time around. So We do have a new mobile dental van under construction. So we have one that got unveiled in 2021, as I just mentioned. And we have a second one that is under construction, and it is made possible by the Mother Cabrini Foundation. It's a faith-based organization that's pretty prominent here in the New York State area. They gave our college $500,000 to build a new mobile medical unit. And the target completion for that mobile center is fall of this year. The concept is a little different, and I can tell you what's shaping that concept. And the concept is really more medical dental integration. So we're not doing kind of the same thing that we already have, but we're thinking about how we can evolve it. And there's a few principles that are driving these sort of integrated care approaches. One is thinking about this cross-trained workforce, right? As we think about a cross-trained workforce, we have to think about what do they know, what are they used to. It's hard for somebody to come into a dental operatory and kind of adapt themselves. We've done that on the current van with our community pediatricians. We're doing a set of things with providers who have done PCR testing and vaccinations, but they're adapting themselves to a largely dental van, right? And so we're trying to learn from that and see what could we do and how can we support experimenting and development of this cross-trained workforce. We look for synergistic services that could be designed as a bundle or delivered synergistically in some way that, we have the patient right here. We would do, preventive oral health screening and then preventive vaccinations for that patient as well during the same visit, as an example. And then we're also thinking about the scholarly connection. Being that we're Columbia, we are charged with producing knowledge. And one of the, I think, weaknesses of our community program in the last 20 years has been that it's really been focused on service. It really has done an exceptional job, as best as it could, on service, but it really hasn't done a lot for kind of scholarly development and publication and really driving the bus, if you will, no pun intended, on new kind of care models, something that could be scaled and something that could be replicated somewhere else. So we really want this 2.0, Dent Care 2.0, to have a scholarly connection. And Mary Beth and I have been talking about opportunities with community-based participatory research and what else can we do in the community that would be beneficial as we deliver health services, that we could also produce knowledge and learn from it. Talked about that again. I mean, opportunities for care innovation. Right now, I mentioned it earlier that the school-based programs are increasingly difficult to maintain for different reasons. They're hard to staff. Staffing is very challenging right now in New York City to get assistants, to get doctors. And we don't have a lot of control over the design of those spaces, maintenance of those spaces, airflow in those spaces. So it's not as ideal. So we're rethinking how we're partnering with school-based centers as well. And so far of the 13 programs that we serve, all have agreed to move to this mobile platform, that we would forgo the brick and mortar old spaces, give them back to the schools, and really build a new fresh program leaning in on new technologies and the new mobile centers that are emerging. Again, we talked about shifting gears and being flexible with regards to vaccine clinics and COVID testing sites. And all of that brings us into new level of thinking of, how can we collaborate better together, right? We do a lot of interdisciplinary education, right? We have projects for our students. We have different ways that we expose them to the professions, but how do we actually structure a set of healthcare delivery and healthcare activities that lean in on the different specialties, and how can they come together around the patient to deliver services in this more integrated way? These are some opportunity areas, screenings, vision, thinking about airway problems. A lot of airway issues and breathing issues are undiagnosed. We don't have early diagnosis on some of the kids, and before you know it, you've got a 50-year-old with sleep apnea that has been probably chronically suffering from a condition that wasn't addressed from early age. So if we can do a set of things through dentistry to identify and do early screening, I think that would really help us with prevention and reduce healthcare cost spending associated with more invasive kind of procedures later on. depression screenings, counseling. There's opportunities to lean in on, nutrition, diabetic prevention that ties to oral health as well. And so how can we, bring these, this cross-trained workforce together to do a set of activities? And so, and finally, like I said, the scholarly connection, again, thinking about research, all of us, how do we bring them into the community and reduce biases by engaging patients, building trust in the communities about participating in various research projects and kind of getting involved with universities with possible research projects. There are opportunities right now with Dr. Peter Gordon, who has a really significant CDC grant on PrEP prevention and PrEP intervention services for men in Brooklyn. And we've started conversations about how can we partner together and get out there with the work that he has on the CDC grant, and how can oral health be sort of embedded into that puzzle as you're out there in the community providing intervention and prevention. So these are the concepts that are driving our decision to build a integrated new mobile medical center that has not just dentistry like the one that I just showed you, but also has primary care capabilities and a setting that providers who are non-dentists would be really comfortable in. So you can see this rendering on the left. Let's see, your left, you could see that there is sort of a traditional dental chair setup with wheelchair lift, and we can accommodate patients there. And on the front is a more or less traditional primary care exam room with, stirrups for women's health and vaccine refrigeration that's all embedded and built in and not an afterthought. And in the middle is sterilization, but also an area for potentially behavioral counseling, where we can integrate healthcare workers and projects that involve healthcare workers to do a set of activities. All of us, if they want to be able to integrate with the activities of the day and catch patients before they check out, to talk about their program, this would be a space for them. And so you can see the design models. I was very involved with this one. And so we're pretty proud to hopefully get it to launch, and you're all invited to the unveiling. That will be sometime in the fall. And again, you could see smart design, right? The pilot seat can pivot around, so it can actually pivot to turn around when it's stationed to then be able to look at Epic, and that way you're sort of facing the patient rather than have your back to the patient. So we've taken the time to really think about ergonomics quite a bit. And I want to show you, these are sort of construction photos from last week. You could see on your left the booth style kind of intake area. But in addition, what we've done for this van is you could see seat belts, right? And you could see on this other rendering jump seats, kind of like the flight attendants. They take a jump seat, so we've got they come up so that we have better footprint when they're not in use. So you have opportunity for 4 people to be in the booth style setting, and then 2 people in the back. You know why we're doing this? Because what we're learning is, as we're doing service learning and we're embedding students in all of these activities, it's very hard to transport them to all these places. And Lyft and Uber and taxi and some of these places with public transportation is not as dependable, or it's not as easy to get to. So we're trying to be able to find ways to transport students. And so with that in mind, as we're adopting and learning about service learning, we're creating a way for us to safely transport people to the sites where they travel to. So lots of little details, but so you could see, this in production, and then it's going to have beautiful photographs, and it's going to be called actually the Mobile Health Center. It's not going to be Mobile Dental Center. It's going to be a Mobile Health Center. So just a word on scaling and what we're learning. We are considering in the future, if we were to scale electric vehicles, and because of the climate impact, at the time when this funding came through, there just weren't vehicles on the market this size that are ready to go quite yet. So in the future, we're thinking about that. We're also thinking about if this model is, a great model and medicine is excited about it, and we have multiple partners, we're thinking about smaller vans, less opportunity for integrated collaboration, but maybe more practical when navigating, New York City traffic. Parking is hard in the city, and that's always a challenge. And these larger 35-foot long vehicles require a driver with CDL Class B license. So those are like truckers, and these individuals are hard to find these days. We've had some challenges staffing for that, but we're finally in a good place. Dental exam rooms are very expensive. As we're learning, medical exam rooms are a lot cheaper to build out. So again, as we're scaling, we're also thinking about what do we need to scale and how much would that be? And satellite connectivity, we're now in Epic. So again, we're bringing those really fancy technologies on the road, but as we're learning, we're going to some of these places that don't have the Wi-Fi connectivity that we're so privileged to have here in our four walls. And so we are seeing challenges with being able to take x-rays and maneuver in Epic the same way that we would in the clinic. And those solutions are, robustly underway, and we're able to provide services, but again, they're not smooth yet as we're learning what the needs are for all of that technology. So you could see we're building partnerships with many individuals and organizations, funders, and really focusing on service learning, big data, and sort of community-based partnerships, and driving new programs, set of activities with a very diverse, very integrated workforce. November of last year for the unveiling. Thank you. Open it up to individuals online to see if you guys have any questions online first.
We've given everybody online the ability to unmute themselves. So if you have a question, please go ahead and do so.
Well, I just wanted to salute you for great work. I worked at a Head Start program, and the dental van was amazing. We would see 25 to 32 children. There was research done at once upon a time a while back. I'm sure I recall a dental student did a research project where she looked at the follow-up that Head Start families had, then going to the dental clinic over there on the corner of Fort Washington, underneath Alan Rosenfield's building. And found that in fact, because of the dental van access, so that parents were so easily able to access services, that really impacted the follow-up they had, and that these programs had greater follow-up than even people going to the clinic downstairs. So just the ability to reach the community has been tremendous. You have this other technology, and that you are now looking to collaborate with other programs is just brilliant. So cheers to you.
We're very fortunate to have recruited a new director. I've put a lot of myself into it in the last couple of years, but I'm also a clinic dean for the whole place. So it's hard to sustain that level of commitment day in, day out that this program requires. So we are very fortunate to have onboarded a new director, Dr. Amy Herbert, who is a pediatric boarded dentist. And she's actually a student at Mailman now, pursuing her MPH. I think she's 1 year down, 1 year to go. And she's been an incredible force with respect to specifically the children's side. I know that Marisela, she's actually rekindling some of that research about continuity of care and commitment to care for patients who have been greeted in the community setting. And we are now working to secure a faculty who would be able to focus on the geriatric component, because I think that those are two uniquely qualified individuals that require support for the program.
Great.
Can I make a short comment? First of all, my name's Steve Stillman. I'm remote here. But congratulations really on a beautiful, meaningful and valuable resource for the community. The last time I saw something like this was about a little over 20 years ago in Geneva, where our colleague Alfredo Marabia, who's on faculty here and is also the editor of the American Journal of Public Health now, he had organized something called Bus 2000, which was sort of a mobile medical unit, which was, I think, partly for screening and partly for population studies. But I'm kind of blown away by the technology and the modernization of the whole concept. So just congratulations, really beautiful. Thank you.
A comment, and you bring something up that I want to, it's really a call to all of you, the minds that are, thinking differently from the dental minds. And, as you see about the opportunities and kind of where we are, we're very much in the experimental stage and very open to thinking about new programming. Reach out and let us know, given what what kind of programs you think might be interesting, and then funding. We sort of haven't really worried too much about funding at this point. We just sort of said, let's just think about what would be meaningful. What does the community find to be of value and service, and money will come. We'll find the money. And so think about programs and reach out if you have ideas.
Well, because I love the dental van, have always loved it, and you served our family so well. We actually approached, I believe, Dr. Aguirre. I don't know, I think she's left, because we were I now work with the Center for Children's Environmental Health. They do a lot of research on environmental toxins. You may know Dr. Herbstman. So we were looking at how could we, tag team with the dental van. It's wonderful that you've done it with the School of Nursing. And they do research, and they have research workers. And we're thinking, well, maybe there's a dental van we can borrow to get to our study participants. I like that you have the layout of this sort of, the living room area, where one of us that does education on environmental toxins could go there and do a little chat while they're, awaiting other services, so that we really integrate all our public health opportunities. And maybe with Dr. Herbstman, maybe we could all think of like, well, how could we integrate our research sort of for this more the scholarly work that you want to do, and how could we work and collaborate? So I know we're very much interested in this possible way of collaborating. So just want to put that out there.
The follow-up. Thank you, Maricela. And Mary Beth, you were saying, do you want to come up and say? Okay. Thank you. Thank you so much. And we're just about at time. Any final questions from either here or online? Paraphrase the question. The question is, how are students trained to collect data, sociodemographic data about the patients that they're seeing in the community? Very good question. So, we are at the College of Dental Medicine aligning with Columbia doctors and the rest of the hospital with the initiative of We Ask Because We Care. And the patients are registered by our staff teams generally. So in other words, right now the van, when it shows up for services, it's got a community partner with whom we are working. We either pre-screen patients with the partner, and then register them and then bring the van around. So by the time the patients are seen, they're already fully registered. And so we do have not just students, the students show up and they're providing services and intervention and education. But we do have staff teams with whom we're working on collecting and doing registration. So it's a full registration, just like a patient would have if they were to be seen in one of our clinics. Does that answer your question? The question again is about capturing race, ethnicity, and demographic data as patients are being registered, because we haven't been very, very good about it in the entire organization as a whole. And I mean, I think I answered it, but I think basically right now there's staff trainings and a big campaign, not just in the College of Dental Medicine, but with the CUHC hospital and Columbia Doctors Ambulatory Network to help staff teams with this. This is part of this campaign called We Ask Because We Care. And it's going to take some time because people there's some stigma around asking for this information, and some patients get upset why they're being asked this information. The students themselves are not, they're not part of that immediate process, but what they are being trained about is social determinants of health information, about employment history and food security and a set of other questions that are in EPIC. And the collaboration with the nurse practitioner students is actually fantastic, because at intake is where we ask a lot of those questions, and having nurse practitioner students to help the dental students kind of guide that conversation has been great. We are working with our faculty as well on making that part of the intake and the full assessment of the patient. And that kind of work just translates simply into the work that we do then in the community as well. Is there a condition? Yes. To the mobile phone. The question is, are there any kind of conditions or funding attached to sending the mobile van out? Well, yes and no. So the condition is that, as I mentioned earlier, the university, when it was building the Manhattanville campus, had a set of commitments to the community that came along with the development of the Manhattanville campus. There are about 300 commitments in total, and they range from education and early education and various things. The College of Dental Medicine has 2 of those 300 commitments, and one of them is service to elderly and operating the mobile dental center. And we have mobile dental center and mobile medical center until the year at least 2035. That's the commitment. There are no funds that were attached to that. And so that's why the dental school has been really working to fundraise. We've gotten $500,000 from the Delta Dental Organization of California for van number 1 that replaced the van that we just decommissioned. And we just got funding by writing grants and proposals. We just got funding from the Mother Cabrini Foundation for a different $500,000 with which we're building van number 2. That's medical dental integrated unit. So the money, there's nothing that's here. Here's money and you run the program and you deliver services at no charge. That doesn't exist. So that's why we have to be really mindful about how do we sustain those services whenever, and we don't turn people away. So if somebody doesn't have insurance, if we're seeing kids in a Head Start program and there's 25 kids that we're going to see in a classroom on that day, if we have, and we have to do the registration in advance and get the parental consents and all of that in advance. If out of the 25 kids, 17 applications came back with, Medicaid or some sort of insurance information, great. But if the other, 7 patients didn't have any insurance information, we're still seeing those kids, and we're not charging. Having me.